Right now, as you're listening to this, there is a 3-pound organ just sitting quietly on the right side of your abdomen.
Yeah, just tucked away under the ribs.
Right. And it's performing, over 500 distinct chemical jobs. You could literally lose 70% of it, and it would just grow back.
Which is an absolute superpower. But there's a really terrifying catch.
It has no pain receptors.
Exactly.
Yeah.
None at all. It could be quietly dying for 20 years, and you wouldn't feel a single thing.
It's just the ultimate silent workhorse. The human liver is filtering toxins, it's manufacturing the proteins that keep your blood actually inside your veins.
And building these incredibly complex cascades that stop you from bleeding to death.
Yeah. But because it suffers in absolute silence, the diagnostic challenge for doctors is just immense.
It really is. By the time a patient actually feels something by the time they show physical symptoms like jaundice or swelling, the damage is often catastrophic.
Which brings us to what we're doing today. Welcome to the Deep Dive. Today we are taking you on a journey into your body's most secretive and resilient organ.
We really want to demystify the complex toolkit that doctors use to investigate the liver when the liver itself just refuses to complain.
Right. We've brought together this massive stack of sources for you. We're looking at primary care medical guidelines, pathology reports, clinical explainers from surgical oncologists, and even recent hematology studies.
And our mission here is to synthesize all of this into a really clear roadmap. We want to understand how a doctor actually figures out what's going wrong inside this black box before it's too late.
Because to do that, we have to look for clues. We can't just peer inside the abdomen.
No, we have to decode the exhaust the liver leaves behind in the blood and then measure its physical density from the outside.
And eventually use some seriously heavy artillery imaging to see the microscopic architecture. So our blueprint for today. We're starting at the microscopic level with the blood.
Then we'll move into the physics of sound waves to measure scarring and fat.
Yeah, and finally, look at the high-definition imaging used to hunt down tumors. And if you've ever, stared blankly at a lab report filled with all those acronyms like ALT and GGT.
This is basically going to be your ultimate translation guide.
Let's jump right in, starting with the blood clues. I'm looking at these primary care guidelines, and the very first thing they talk about is the LFT panel, the liver function test. But the sources suggest this name is actually a bit of a lie.
Oh, it's a profound misnomer. When we hear liver function test, we naturally assume the blood work is going to tell us, well, how well the liver is doing its job.
Right, functioning.
Exactly. But many of the markers in a standard LFT panel aren't direct measures of function at all. They're measures of injury.
Wait, so they just tell us if the cells are taking damage?
Yes, not necessarily if the overall organ is failing. And the guidelines state that up to 9% of completely asymptomatic people have elevated liver enzymes.
9%. That's almost 1 in 10 people just walking around with red flags on their blood work feeling totally fine.
Yeah, totally fine. So let's break down what these enzymes actually are.
Okay, yeah. If I have a high ALT or AST on my report, what is physically happening inside my body?
So let's start with the anatomy of the cell. The main functional cells of your liver are called hepatocytes.
Hepatocytes, okay.
And inside these hepatocytes, you have enzymes like ALT, which is alanine aminotransferase, and AST, aspartate aminotransferase.
Right, those are the ones you always see on the test.
Exactly. And these are essentially microscopic protein machines that help the cell process amino acids and generate energy. They belong inside the cell.
So, if they are in my bloodstream...
Something has gone wrong.
Okay. The cells are breaking open.
Exactly that. When a hepatocyte is injured, whether that's by a virus or alcohol or toxic medications, the cell membrane becomes unstable.
And then it ruptures.
Yeah, it eventually ruptures. The cell dies, bursts open, and spills all of its internal contents directly into the bloodstream.
Including those ALT and AST enzymes.
Right. So when a doctor draws your blood and sees high levels of these enzymes, they aren't measuring liver function. They're measuring a cellular massacre.
Wow. A cellular massacre.
Yeah, we call this a hepatocellular injury pattern.
Okay, looking at the specific numbers from our sources, they keep emphasizing ALT over AST. What makes ALT the smoking gun for liver damage?
Well, it really comes down to real estate.
Oh.
AST is found in the liver, sure, but it's also found in high concentrations in your heart, your skeletal muscles, your kidneys.
Even your brain, right?
Even your brain, yeah. So if a patient comes in with high AST, but their ALT is normal, the doctor might suspect they just, ran a marathon and damaged some muscle tissue.
Or maybe they're having a heart issue.
Exactly. But ALT is almost entirely exclusive to the liver. If the ALT is elevated, the spotlight is firmly, unavoidably on the liver.
Okay, that makes sense. Now, the normal reference range for ALT is roughly 0 to 40 units per liter. But our pathology sources explicitly state that if a patient's ALT hits above 600,
Yeah, 600 is a big deal.
it says the pathology lab will literally pick up the phone and urgently call the requesting clinician. That's like a blaring siren. What is happening in a liver with an ALT over 600?
An ALT that high indicates massive acute destruction of liver tissue. I mean, the hepatocytes aren't just slowly degrading over time, they are being wiped out in waves.
Like a forest fire.
Exactly like that.
Yeah.
This is what you see in acute viral hepatitis, or very commonly, in a severe acetaminophen overdose.
Paracetamol, for our listeners outside the U.S., let's drill down into that because acetaminophen is something literally everyone has in their medicine cabinet. How does a normal painkiller cause an ALT of 600?
It's all about how the liver filters toxins. When you take acetaminophen, your liver breaks it down into a highly toxic byproduct called NAPQI.
Wait, the liver turns it into a toxin?
Well, it's an intermediate step. Normally, your liver has a built-in neutralizing agent called glutathione, and that instantly neutralizes this NAPQI toxin.
Okay, so it handles it safely.
Right. But if you take a massive overdose, you completely deplete your liver supply of glutathione. It just runs out.
And so the toxin just builds up.
Yes, the NAPQI toxin builds up. It binds to the proteins inside the hepatocytes, and it literally shreds the cells from the inside out.
Oh, wow.
Yeah, millions of cells burst simultaneously, dumping massive amounts of ALT into the blood. So that phone call from the lab...
That's the warning that the patient's liver is actively burning down.
Exactly. It's an emergency.
That is terrifying, but it paints such a clear picture of what hepatocellular injury actually means. But there is a second pattern in the blood work we need to cover.
Right, the cholestatic pattern.
Yeah. If ALT and AST are the alarms for the cells burning down, what are ALP and GGT?
Well, if the first pattern is about the factory workers dying, this second pattern, cholestatic, is about the plumbing getting blocked.
Cholestasis. That refers to what? A reduction or stoppage of bile flow.
Precisely.
Let's define bile quickly, because I think a lot of people just think of it as stomach acid, and that's not right.
Not at all. Bile is this complex greenish-yellow fluid manufactured by the liver. It contains bile acids, cholesterol, and waste products.
And its main job is to flow down through these microscopic tubes, the bile ducts out of the liver and into the intestines, right?
Yeah, to help you break down and absorb dietary fats. But if those tubes get blocked, maybe by a gallstone or a tumor or even severe inflammation...
The bile basically backs up into the liver.
Exactly. And when that plumbing backs up, the pressure inside the liver starts to build.
And I'm assuming that pressure irritates the cells lining those ducts.
You've got it. In response to that mechanical stress, those duct cells start overproducing an enzyme called ALP, alkaline phosphatase.
Okay, and then the ALP leaks into the bloodstream.
Right, so a high ALP tells the doctor, hey, the pressure in the pipes is too high.
But just like AST earlier, ALP isn't exclusive to the liver, is it?
No, it isn't. ALP is also found in really high concentrations in your bones. It's used by the cells that build new bone tissue.
Oh, interesting. So growing children would naturally have high ALP.
Exactly. Their skeletons are actively growing, so their ALP levels are sky high compared to an adult. And adults with bone diseases or maybe a healing fracture, they'll also have high ALP.
So if an adult patient comes in with an isolated high ALP, how does the doctor know if it's a blocked bile duct or like a hidden bone problem?
That's where they look at the next acronym on the panel, GGT, gamma-glutamyl transferase.
And what does GGT do?
It's another enzyme heavily concentrated in the liver and bile ducts, but crucially, it is not found in bone. Yeah, so if a patient has high ALP and a high GGT, the doctor can definitively say, okay, the problem is the liver's plumbing.
But if the ALP is high and the GGT is completely normal...
And the liver is fine, and the doctor needs to start looking at the patient's skeleton.
It's just biological cross-referencing. You need two pieces of the puzzle to confirm the location.
Exactly.
And that brings us to bilirubin, which is probably the one word on the LFT panel people actually recognize, mostly because of jaundice.
Right, the yellowing of the skin.
Yeah. Why does a backed-up liver turn a person yellow?
Well, bilirubin is a waste product. Specifically, it's the garbage left over from dead red blood cells.
Okay.
Your red blood cells have a lifespan of about 120 days. When they get old and brittle, your spleen breaks them down. The hemoglobin inside them, the stuff that carries oxygen, is dismantled.
And one of the leftover components is this yellowish pigment called bilirubin.
Yes. And normally, The liver takes out this trash. It pulls this bilirubin out of the bloodstream, processes it to make it water-soluble, and dumps it into the bile to be flushed out of the body in your stool.
In fact, our sources mentioned that processed bilirubin is actually what gives human stool its normal brown color.
It is, yeah.
So normal bilirubin levels in the blood are very low, under 20 micromoles per liter. But if the bile ducts are blocked, if we have that cholestasis we just talked about,
The trash has nowhere to go. The liver keeps pulling bilirubin from the blood, but it can't dump it into the intestines, so it leaks backward into the general circulation.
and because it's a highly pigmented yellow molecule, it just starts circulating throughout the body.
Right, and depositing in the tissues. It has a high affinity for a protein called elastin, which is really abundant in your skin and in the sclera, the whites of your eyes.
Which is why the eyes are often the very first place a doctor looks for jaundice.
Exactly.
But our primary care guidelines have a really, really important caveat here. You can have an isolated high bilirubin level without actually having liver disease at all.
This is a crucial point, and it saves a lot of patients from unnecessary anxiety. About 5% of the general population has a harmless genetic quirk called Gilbert syndrome.
5%, that is a lot of people. What exactly is happening in Gilbert syndrome?
It's just a tiny glitch in the manufacturing line. People with Gilbert's have a slight deficiency in the specific liver enzyme responsible for processing bilirubin.
The UGT1A1 enzyme.
Yeah, that one. Their livers work perfectly in every other way, but they are just a little slower at taking out the bilirubin trash.
Okay, so what triggers it to build up?
When these individuals are stressed or fasting or maybe fighting off a cold, their bilirubin levels spike. They might even get slightly jaundiced.
But it causes zero permanent damage.
None. It requires absolutely no treatment.
So if a patient has high bilirubin, but their ALT, AST, ALP, and GGT are totally normal, the doctor can look at that pattern and say, hey, your liver isn't burning down, the plumbing isn't blocked, you just have Gilbert's.
And that is exactly why we don't just treat individual numbers, we treat patterns.
Okay, so we've looked at the enzymes that indicate the factory is burning or the plumbing is blocked. Now we need to look at the markers that actually do measure the function of the liver.
The synthetic markers.
Right. Let's talk about albumin.
So the liver is fundamentally a massive manufacturing plant, and albumin is one of its most important products.
It's a protein, right?
Yes, made exclusively by the liver. And it accounts for about half of all the protein in your blood plasma. Its normal range is 35 to 50 grams per liter.
I really want to dig into what albumin does because the physics of it are just fascinating. It essentially keeps our blood from leaking out of our veins. How does a protein do that?
It works through a biological principle called osmosis.
Okay.
Water naturally wants to move from an area of low solute concentration to an area of high solute concentration. It wants to dilute things that are salty or protein rich.
So because albumin is this large, bulky protein, and the liver pumps so much of it into the bloodstream,
The blood becomes highly concentrated with protein compared to the tissue surrounding the blood vessels.
got it. So the water in the surrounding tissues is constantly trying to push into the blood vessels to dilute the albumin.
Exactly. This pulling force exerted by albumin is called oncotic pressure.
Oncotic pressure.
Right.
And at the same time, your heart is pumping blood, which creates hydrostatic pressure, a force trying to push fluid out of the blood vessels.
Right. And in a healthy person, the pushing pressure of the heart and the pulling pressure of the albumin are perfectly balanced. The fluid just stays in the pipes.
But what happens if the liver is failing and it stops manufacturing albumin?
Well, the albumin levels in the blood drop. That pulling force, the oncotic pressure, disappears. Suddenly, the pushing force of the heart wins out.
And fluid begins to leak out of the microscopic capillaries and into the surrounding tissues.
Exactly. Gravity pulls this leaked fluid down, so the patient's legs and ankles swell up massively, or the fluid leaks into the empty space in the abdominal cavity, causing the belly to swell with liters of water.
That's a condition called ascites, right?
Yes, the sites.
This really highlights the difference between an acute injury and a chronic failure. Like if I take a massive overdose of acetaminophen today, my ALT will spike to 600 because the cells are dying. But my albumin will probably still be normal, right?
Yes, it would be. The liver has already manufactured a massive supply of albumin, and it takes about 20 days for the albumin currently in your blood to degrade.
Oh, okay. So an acute injury won't show a drop in albumin immediately.
No. But if a patient has cirrhosis, where the liver has been slowly replaced by scar tissue over, say, 20 years, their factory has been permanently dismantled. Their albumin will be consistently, dangerously low.
So to summarize this first set of clues, tell me if this analogy holds up.
Sure.
The ALT and AST are like the smoke alarms. They only go off when the factory floor is actively on fire.
I like that.
The ALP and GGT are the sensors in the shipping department. They go off when the loading docks are blocked.
Spot on.
And measuring albumin is like checking the factory's long-term output logs. It tells you if the fundamental infrastructure has been permanently compromised.
That is a perfect synthesis of the LFT panel.
But the liver manufactures more than just albumin. And that brings us to a massive, often overlooked clinical risk. We've mapped out the chemical fires, but blood is just the exhaust. What happens when the factory stops making the exact materials that keep us from bleeding to death?
We have to look at the coagulation cascade.
This is the biological process that creates a blood clot.
Yes. And the liver is entirely responsible for manufacturing almost every single protein involved in this life-saving domino effect.
We have a fascinating study in our sources. It's titled Prothrombin Time and Activated Partial Thromboplastin Time in Case of Liver Disease.
A very literal title.
Very. They looked at 100 patients to see exactly how these clotting pathways break down. But before we get into their data, we really need to understand the mechanism. What exactly is a coagulation cascade?
Imagine a massive, complex setup of dominoes. When you get a cut, your body needs to form a physical plug to stop the bleeding.
Right.
The ultimate goal of this domino effect is to take a dissolved, floating protein called fibrinogen and activate it into a sticky web-like mesh called fibrin.
Fibrin. And that mesh catches the red blood cells and platelets, forming a solid clot.
Exactly. But the body can't just have sticky fibrin floating around all the time, or our blood would just turn to jelly in our veins.
Right, that would be instantly fatal.
So the proteins circulate in an inactive sleeping state. We call them coagulation factors, and they're numbered with Roman numerals.
Okay, so when an injury occurs.
Factor 12 wakes up and activates factors Landerova. Factor 11 activates factor IX, and so on, cascading down until that fibrin web is formed.
And the tests we use to measure this are PT prothrombin time and ARA-PTT. How do these tests work?
They measure different starting points of the domino setup. The coagulation cascade has two main starting pathways that eventually merge into one final path.
Okay.
The BT test measures the extrinsic pathway. It tests how long it takes for the blood to clot when we expose it to tissue damage outside the blood vessel.
Extrinsic outside, got it.
And the APTT test measures the intrinsic pathway, which is how the blood clots when it's exposed to internal damage, like a collagen underneath a damaged blood vessel lining.
Okay, so back to the study. They took 100 patients, 49 had cirrhosis, 44 had hepatitis, and 7 had other liver diseases. What happens to the dominoes when the liver is sick?
The data paints a stark picture of chronic versus acute damage. In the patients with hepatitis, which is an inflammation of the liver like an acute fire, the clotting times were largely unaffected.
Oh, really?
Yeah. Only 13.6% had a prolonged PT, and a mere 4.5% had a prolonged APTT. The liver was inflamed, but the factor was still churning out those coagulation factors.
But then we look at the cirrhosis patients. Cirrhosis is the end stage, right?
Yes. The healthy liver tissue has been physically strangled and replaced by hard, fibrous scar tissue.
And in these patients, a massive 73.5% had a prolonged prothrombin time. Over half, 53.1%, had a prolonged APTT. And nearly half had a prolongation of both tests.
It just demonstrates the absolute destruction of the liver's synthetic capacity. The hepatocytes that manufacture those Roman numeral coagulating factors have been physically obliterated by scar tissue.
The body literally does not have enough dominoes to complete the cascade. The study also noted something else. In the cirrhosis patients, 65.3% had abnormally low platelet counts. Now, platelets are the sticky cell fragments that form the initial plug in a wound before the fibrin web locks it down. Why do platelets disappear in cirrhosis?
That is a mechanical problem caused by the scarring.
Okay, how so?
As the liver fills with dense scar tissue, it becomes very difficult for blood to flow through it. The blood backs up in the portal vein, which is the massive pipe bringing blood from the intestines to the liver.
So it's a pressure backup.
Right, and this backup of pressure forces the blood to reroute, and a lot of it gets shoved into the spleen. The spleen swells up like a balloon and starts aggressively filtering out and destroying platelets.
Wow. So a patient with cirrhosis lacks the sticky platelet plugs and the protein glue to hold a clot together.
Which is a very dangerous combination.
Which brings us to the real-world consequences of this study. The researchers tracked which patients experienced severe gastrointestinal bleeding.
And the correlation was undeniable. Patients with prolonged PT, APTT, and low platelets were at a massively higher risk of life-threatening hemorrhages.
But how does liver disease lead to a gastrointestinal bleed specifically?
It goes back to that backed up pressure in the portal vein. Because the blood can't get through the hardened liver, it looks for detour routes to get back to the heart.
Okay.
It forces its way into the tiny, fragile veins in the lining of the esophagus and the stomach. These veins balloon outwards, forming what we call varices.
Garcias.
Yeah, they're like overinflated bicycle tires. If one of these fragile varices bursts, and the patient has no coagulation factors because their liver is dead.
They can bleed to death internally in a matter of minutes.
Exactly, it's catastrophic.
So a prolonged PT test isn't just an abnormal number on a page. It's a crystal ball predicting a catastrophic bleed.
Yes, it is.
But I want to ask about a specific mechanism here, looking at the study. It shows that PT is prolonged in 73.5% of cases, but APT is only prolonged in 53.1%. If the liver makes the factors for both pathways, why does the extrinsic pathway measured by PT break down so much faster?
That comes down to the lifespan of one specific protein, factor 7.
Factor 7.
Factor 7 is the absolute linchpin of the extrinsic pathway, which is what's measured by the PT test. And factor 7 has the shortest half-life of all the coagulation factors, only about 4 to 6 hours.
Meaning that once it's released into the blood, half of it degrades and becomes useless in just a few hours?
Precisely. The factors involved in the intrinsic pathway, measured by APT, they take much longer to degrade. So imagine the liver factory suddenly shuts down today.
Okay.
The supply of the intrinsic factors will linger in the blood for days, but the supply of factor 7 will vanish by tonight.
That is incredible. So the PT test will show an abnormality within hours of severe liver failure, long before the APTT test budges.
Yes. It is the most sensitive early warning system we have for a failure in the liver's manufacturing capacity.
So we've mapped out the chemical fires with the LFTs, and we know if the factory is bleeding out with the PT test. But blood tests are ultimately just indirect clues. They are the exhaust fumes.
Right. They don't show us the physical ruins of the factory.
Exactly. If a doctor wants to actually see the scarring or measure the fat physically choking the cells, how do they do that without cutting the patient open?
For a very long time, they couldn't. If a doctor wanted to know the exact degree of scarring, the fibrosis, they had to perform a percutaneous liver biopsy.
Which involves pushing a long, thick needle through the skin, right between the ribs, and physically punching out a core of liver tissue.
It is an invasive, painful procedure. And consider the irony here.
Yeah.
We just established that patients with advanced liver disease have a massive risk of uncontrolled bleeding because they lack clotting factors.
Oh, wow.
Yeah. So taking a large needle and punching a hole in a highly vascular organ in a patient who cannot clot is inherently dangerous.
That makes total sense. So there was a desperate need for a non-invasive way to feel the physical structure of the liver. Let's talk about the first-line imaging, the standard ultrasound.
So a standard right upper quadrant abdominal ultrasound uses high-frequency sound waves to create a grayscale visual image of the organs. It's cheap, it's non-invasive, and totally painless.
And if a patient has that cholestatic pattern on their blood work, the high ALP and GGT indicating a blocked pipe, the ultrasound is the absolute first step.
Because it can visually see the blockage. It's fantastic for spotting gallstones in the gallbladder or seeing if the common bile duct is swollen and dilated from a blockage further down.
But a standard ultrasound has severe limitations, right? Like, it can show you the shape of the liver, but it struggles to tell you how stiff the tissue actually is or exactly how much fat is trapped inside the cells. It just looks like a gray blob.
Which is why the invention of the FibroScan completely revolutionized hepatology.
The technical term for it is vibration-controlled transient elastography, or VCTE.
Yeah, quite a mouthful.
We have medical policy documents from AWS stating that FibroScan is now considered a medically necessary alternative to the traditional needle biopsy for assessing chronic viral hepatitis and alcoholic fatty liver.
Yes.
How does it actually work? Because it's not just taking a picture.
No, it isn't. It looks like a standard ultrasound probe, but it functions entirely differently. When the doctor places the FibroScan probe against your ribs, it fires a mechanical pulse, a low-frequency 50 Hz elastic shear wave, directly into the liver.
Wait, it physically thumps the liver?
It generates a shock wave. And then the ultrasound component of the probe acts like a radar gun, tracking exactly how fast that shear wave travels through the liver tissue.
And the physics here are brilliant. Our sources use an analogy. If you bounce a bowling ball on a tight, stiff trampoline, the shock wave travels across the fabric incredibly fast.
Right.
But if you bounce that same ball on a loose, soft mattress, the wave gets absorbed and travels very slowly.
That is the exact principle. A healthy liver is soft and elastic, like a sponge. The shear wave travels slowly. But a liver riddled with fibrosis, where the soft tissue has been replaced by dense collagen scars, is hard and stiff. The faster the wave travels, the stiffer the liver, and the more severe the permanent damage.
The machine calculates this speed and spits out a stiffness score measured in kilopascals, or kPa. Let's walk through the clinical stages of this score from F0 to F4 because this is what patients actually see on their lab results.
Sure, F0 means no scarring. The wave travels slowly through a healthy, soft organ.
Then we hit F2, which our hepatologist sources define as moderate fibrosis. This seems to be a critical crossroads for a patient.
It really is the window of opportunity. At F2, the liver is laying down scar tissue, but the architecture hasn't permanently collapsed yet.
So it's fixable.
Yes. If the patient removes the stressor, whether that's stopping alcohol consumption, curing a hepatitis C infection, or losing weight, the liver can actually dissolve that early scar tissue and regenerate back to F0.
But if they ignore it, the score pushes up into F3, advanced fibrosis.
And at F3, the scar tissue is forming thick bands across the liver, literally strangling the blood supply. The capacity to reverse the damage is shrinking rapidly. An F3 result requires urgent specialist intervention, usually within weeks, to halt the progression.
And the final stage is F4, which is cirrhosis. At this point, the trampoline is pulled as tight as it can go. The wave travels incredibly fast because the liver is essentially a hard nodular rock of collagen.
At F4, the damage is largely irreversible. The clinical focus shifts entirely to managing the fallout.
Right.
The patient needs intense surveillance, including an ultrasound every 6 months, because a cirrhotic liver is a hyperinflammatory environment. It is the prime breeding ground for hepatocellular carcinoma primary liver cancer.
But the FibroScan is a dual threat machine, isn't it? It doesn't just measure the speed of the wave to find stiffness, it simultaneously measures something called the CAP-P score to find fat.
Yes, the controlled attenuation parameter. This is vital because fatty liver disease, which is now formally called MASLD, or metabolic dysfunction-associated steatotic liver disease, is an absolute epidemic.
Yeah.
It is currently the most common liver condition in the Western world.
How does fat actually damage the liver? We talk about it all the time, but what is the cellular mechanism?
It ties back to insulin resistance and metabolic syndrome. When the body has excess calories and high insulin levels, it starts storing fat directly inside the hepatocytes.
Inside the functional cells.
Right. These microscopic fat droplets accumulate, swell up, and literally physically crush the internal machinery of the cell.
Ouch!
Yeah. This causes inflammation. The cell calls out to the immune system. The immune system attacks the fat-laden cell. And in a crossfire, scar tissue is laid down.
And the CIP score measures exactly how much fat is crushing those cells. How does it do that?
It works by measuring how much the ultrasound signal is weakened or attenuated as it passes through the tissue.
Because fat acts like an acoustic muffler.
Exactly. The more fat droplets inside the liver, the weaker the returning ultrasound signal, and the higher the CIP score, which is measured in decibels per meter.
Our sources provide the reference table for this. Below 238 is an S0, meaning no significant fat. If you score between 260 and 290, you are at S2, moderate fatty liver, and anything over 290 is S3, severe fatty liver, where over 67% of your liver cells are bogged down with fat.
Being able to quantify both fat and scarring simultaneously in a painless 5-minute outpatient appointment has fundamentally changed how we track liver disease.
But there's a massive caveat in the literature. You cannot just read the numbers off a FibroScan printout and panic. The machine can be fooled.
Oh, absolutely. Context is everything here. A FibroScan measures physical stiffness, but scar tissue isn't the only thing that makes a liver stiff.
Right.
If a patient eats a heavy meal just before the scan, their digestive tract demands a massive surge of blood. That blood flows through the portal vein and into the liver, engorging it. The liver swells slightly, stretching its outer capsule tight like a water balloon.
So the physical pressure of the extra blood makes the liver stiff, and the machine misinterprets that as scar tissue. You could eat a massive burger, get scanned an hour later, and the machine tells you that you have F4 cirrhosis.
Exactly.
Yeah.
The same false positive happens if a patient has right-sided heart failure.
How so?
If the heart is too weak to pump blood forward, the blood backs up into the liver, congesting it. The stiffness is caused by hydraulic blood pressure, not collagen scars.
Which is why patients must fast for at least 3 hours before a scan, and why a doctor must interpret the results in the context of the patient's overall health.
Precisely.
Here is a fascinating paradox from the clinic guide. What if a patient gets their results and their KIAP score, the FAT score, is an S3, meaning their liver is profoundly fatty, but their kPa stiffness score is completely normal at F0? Is that a contradiction?
It's actually the most hopeful scenario a hepatologist can see for a MAS LD patient.
Really?
Yeah. It means the hepatocytes are packed with fat, but the immune system hasn't started the inflammatory crossfire yet. No scar tissue has been laid down.
So it's completely reversible.
Highly reversible. Because there is no structural damage, a mere 5 to 10% reduction in overall body weight can cause the liver to rapidly unpack and burn that stored fat.
Wow.
In a matter of months, they can completely cure the condition. The FibroScan caught it exactly in time.
So we have the blood tests for the chemistry and the sound waves for the overall density and fat content. But what if the ultrasound spots a strange shadow?
Right, what if there's a mass?
Yeah. What if the doctor suspects a tumor or needs to know if colon cancer has spread to the liver? Thumping the organ with a shear wave won't give you a map. We have to escalate to the heavy artillery.
When we are hunting for specific lesions, measuring their exact blood supply, or planning a complex surgical resection, we move to high-definition cross-sectional imaging, the CT scan and the MRI.
We have insights from Dr. Sanket Mehta, a surgical oncologist, who addresses the most common question patients ask: should I get a CT scan or an MRI? Which one is a better machine?
And the surgical answer is that better depends entirely on the biological question you are trying to answer. Let's start with computed tomography, the CT scan.
A CT scan uses X-rays, right? The machine rotates around the body, taking thousands of thin X-ray slices, and a computer rebuilds them into detailed 3D images. What makes the CT scan so valuable for a surgeon?
Three things, really. Speed, anatomical clarity, and volumetric math. A CT scan takes just a few minutes. To make the tumors visible, the patient is injected with an iodine-based contrast dye.
Okay.
Because tumors are highly vascular, they grow their own messy blood supply to feed themselves. The iodine dye rushes into the tumor and lights it up white on the X-ray, stuck against the gray background of the normal liver.
Dr. Mehta notes that for a patient newly diagnosed with colorectal cancer, the CT scan is the immediate go-to.
Because of its speed. A CT scan can capture the chest, the abdomen, and the pelvis in one single breath hold. The surgeon can instantly see if the colon cancer has metastasized to the liver, the lungs, or the surrounding lymph nodes.
It provides the ultimate whole-body battlefield map. And you mentioned volumetric math. How does a CT scan help a surgeon do math?
Well, if a surgeon has to remove a large tumor from the liver, they face a critical biological limit. They have to leave enough healthy liver behind, called the future liver remnant, to keep the patient alive while the organ regenerates.
That makes sense.
A CT scan uses units of measurement called Hounsfield units to calculate the precise cubic millimeter volume of the liver. The surgical team can digitally map out their scalpel cuts on the computer and mathematically prove that the remaining liver volume will be sufficient.
Okay, so the CT scan is fast, it's great for whole-body staging, and it's mathematically precise. Where does the MRI come in?
Magnetic resonance imaging operates on an entirely different plane of physics. There are no X-rays at all.
Just magnets.
Huge ones. The patient lies inside a massive, supercooled electromagnet. The magnetic field forces all the protons in the water molecules of your body to align. Then the machine fires radio frequency pulses to knock them out of alignment.
And then what?
When the radio pulse turns off, the protons snap back into place, releasing their own tiny radio signals. The MRI machine listens to those signals to build the image.
Which is why it takes so long, often 45 to 60 minutes, and why you have to lie perfectly still inside a tight tunnel. It's an incredibly complex physical process. But what is the clinical advantage of using magnets instead of X-rays?
Soft tissue contrast. The MRI is unparalleled in its ability to differentiate between subtle types of internal tissue. While a CT scan looks at the physical density of a tissue, an MRI looks at the chemical composition.
So it can see like how much water, how much fat, or how much iron is inside the cells.
Exactly.
Dr. Mehta points out that an MRI can detect hidden tumors smaller than 1 centimeter that a CT scan completely misses, especially if the liver has a background changes. Let's explore that. What does a cirrhotic liver look like on a CT scan versus an MRI?
On the CT scan, a cirrhotic liver is a visual nightmare. The entire organ is lumpy, irregular, and dense with scar tissue. Because X-rays only see density, a small, newly forming tumor looks exactly like a dense nodule of scar tissue. It's visual static. The tumor perfectly camouflages itself.
But the magnetic fields of the MRI cut right through that static.
They do. Because the MRI is measuring the behavior of water molecules, it can easily tell the difference between a dead, dry nodule of collagen scar tissue and a hypercellular, actively growing cluster of cancer cells.
Wow.
Yeah, for patients with classical hepatocellular carcinoma, which almost always grows inside a scarred cirrhotic liver, the MRI is the ultimate lie detector test.
Our sources also highlight a rare condition where MRI is absolutely vital, fibrolamellar HCC.
Yes. This is a devastating, unique variant of liver cancer that typically strikes adolescents and young adults who have completely healthy livers.
And the defining feature of fibrolamellar HCC is its physical architecture. It has fibrous bands, or lamellae, running through the center of the tumor.
A CT scan will show a large mass, but it often can't resolve those internal fibrous layers. An MRI, however, can highlight those internal bands with exquisite detail, allowing the radiologist to confirm the exact diagnosis without needing a biopsy.
But Dr. Mehta strongly pushes back against the patient assumption that MRI is always better because it's higher tech.
It's a dangerous assumption. Clinical reality dictates our tools. If a patient comes into the ER in agonizing abdominal pain, they cannot lie perfectly still in a claustrophobic magnetic tunnel for an hour.
Right.
They need answers in 2 minutes. That means a CT scan.
There are also strict physical limitations with MRI. Anyone with a pacemaker, certain metallic implants, or retained shrapnel cannot enter the magnetic field.
And we have to consider the contrast dyes.
Yeah.
CT scans use iodine, which is generally safe but can damage the kidneys in vulnerable patients, a condition called contrast-induced nephropathy.
What about MRI?
MRI uses a gadolinium-based dye, which is safer for mild kidney issues. But if a patient has severe end-stage kidney failure, gadolinium can trigger a rare, horrific disease called nephrogenic systemic fibrosis.
Nephrogenic systemic fibrosis.
Yes, where the body, skin, and internal organs rapidly harden and turn to stone.
Oh my goodness. So a doctor is constantly weighing a dozen variables. The need for speed, the claustrophobia, the kidney function, the type of tumor, and the background scarring of the liver.
Medicine is never about finding the single best tool. It is about sequencing the right tools in the correct order to solve a specific biological mystery.
Which perfectly sets up our final section. We've looked at the blood chemistry, the sound waves, the x-rays, and the magnets in isolation. Let's look at how a clinician actually strings these tools together in real time.
We have a brilliant case study from the primary care guidelines. The scenario is called Unexplained Liver Injury, Searching for the Cause.
Here is the setup. A patient is diagnosed with diverticulitis, which is a painful bacterial infection in the pouches of their colon. The doctor prescribes a very common standard antibiotic, amoxicillin clavulanate, to be taken for 7 days.
Right.
A few weeks later, the patient isn't feeling well and routine blood tests are drawn.
And the LFT panel comes back with a glaring abnormality. The ALT and AST, the smoke alarms for cellular death, are relatively normal, but the ALP and the GGT are sky high.
Relying on our translation guide from earlier, this is a distinct cholestatic pattern. The factory cells aren't bursting open, but the plumbing is backed up. The pressure in the bile ducts is rising.
The biochemical compass is pointing directly at the biliary tree. The doctor's immediate overriding priority is to rule out a mechanical obstruction.
They have to assume there is a physical boulder in the pipe?
Exactly, like a gallstone that has slipped out of the gallbladder, or a tumor physically compressing the common bile duct.
So what is the very first diagnostic move? The case study presents options. Do we order a liver biopsy? Do we jump straight to an MRI? Or do we just wait 4 weeks and see if the blood tests improve?
The guidelines are absolutely adamant you never watch and wait a blocked pipe because stagnant bile rapidly breeds deadly infections.
Okay.
A liver biopsy is completely useless here. Punching a hole in the tissue won't tell you if the main exhaust pipe is blocked. The correct mandatory first step is the right upper quadrant abdominal ultrasound.
Because it's fast, cheap, uses zero radiation, and is highly sensitive for finding large physical obstructions.
Yes. The ultrasound technician will look at the common bile duct. Normally, it should be thin, just a few millimeters across. If there is a blockage, the duct behind the blockage will swell up like a balloon to 10 or 15 millimeters.
But let's follow the case study's twist. The patient gets the ultrasound, and the radiologist's report comes back completely clean. No gallstones. The bile ducts are perfectly thin. The ultrasound sees absolutely no boulder in the pipe.
And this is the crux of internal medicine. The blood chemistry is screaming that the pipe is blocked, but the acoustic imaging says the pipe is clear. Do you send the patient home?
You can't. The ALP and GGT don't lie.
Exactly. The clinical suspicion remains high. The doctor understands the limitations of their tools. The ultrasound is fantastic for spotting big blockages in the main pipes, but it cannot resolve the microscopic, hair-thin bile ducts deep inside the liver tissue.
The hidden cracks.
Yes. So step 2 in the clinical pathway is to escalate to the MRI, but not just a standard MRI. The doctor orders a highly specialized protocol called an MRCP magnetic resonance cholangiopancreatography.
Wow. How does an MRCP differ from a regular MRI?
It exploits a brilliant piece of physics. The MRCP protocol is heavily weighted to make stationary fluid shine brilliantly white, while solid tissue and flowing blood turn pitch black.
Oh, that's clever.
Right. Bile is a relatively stationary fluid. So without injecting any contrast dye at all, the MRI machine uses the patient's own bile as a natural contrast agent. It produces a luminous, high-definition 3D map of the entire biliary tree right down to the microscopic branches inside the liver.
It illuminates the exact location of the blockage. So what does the MRCP show for our patient?
Well, in this case study, the MRCP also comes back completely normal. The microscopic ducts are perfectly healthy. There are no strictures, no tiny tumors, no physical blockages of any kind.
The blood says there is a blockage. The ultrasound and the high-def MRI prove there is absolutely no physical blockage. How do we solve this?
By combining the biochemistry, the clear imaging, and the patient's history. The doctor looks back at the chart and sees the prescription for amoxicillin clavulanate. They diagnose the patient with drug-induced liver injury, specifically causing intrahepatic cholestasis at the cellular level.
Wait, the antibiotic caused the blockage?
Yes. In rare cases, the clavulanate component of that antibiotic can trigger a severe inflammatory reaction in the tiny transport proteins on the surface of the hepatocytes. The cells simply stop pumping bile into the ducts. The chemistry of the blood shows cholestasis because the bile isn't flowing, but the imaging is clear because the blockage isn't a physical stone. It's a microscopic chemical paralysis of the cellular pumps.
The blood gave us the what cholestasis. The imaging ruled out the where there was no physical obstruction. And the patient's history provided the why, the antibiotic. It's a beautiful process of systematic elimination.
You start broad and cheap with the ultrasound, you escalate to the precise and complex MRCP, and you synthesize all of it with the biochemical clues in the blood.
We have covered an immense amount of biological terrain today. We started by decoding the distress signals in the blood. We learned that an ALT over 600 is the siren of hepatocytes bursting open from viral attacks or paracetamol overdoses. We learned that ALP and GGT are the cross-reference clues that prove the bile plumbing is blocked.
We explored the sheer mechanical brilliance of the liver's synthetic capacity. We discussed how albumin utilizes oncotic pressure and osmosis to hold water inside our blood vessels, preventing massive swelling.
Yeah.
And we mapped the deadly consequences of the coagulation cascade breaking down, specifically how the rapid degradation of factor VII causes the PT test to spike, warning us that a cirrhotic patient is at imminent risk of a catastrophic internal bleed from varices.
We then transitioned into the physics of sound waves, exploring how the FibroScan uses a 50 Hz mechanical shear wave to thump the liver, reading the acoustic speed to measure stiffness and fibrosis, while simultaneously calculating the attenuation of the wave to measure the exact percentage of fat crushing the cells in MASLD.
And finally, we witnessed the ultimate imaging showdown. The raw speed and Hounsfield unit math of the CT scan against the unparalleled soft tissue proton mapping of the MRI.
It is a remarkable, continuously evolving toolkit. But as we wrap up this deep dive, I want to leave you with a final thought to ponder. For nearly a century, the absolute gold standard in hepatology, the only way a doctor could truly know what was happening deep inside the microscopic architecture of the liver was a painful, inherently risky percutaneous needle biopsy. You had to physically punch a piece of the organ out of the body to find the truth.
It was barbaric, but necessary at the time.
But look at the clinical reality we just walked through. With the advent of vibration-controlled transient elastography that can literally feel the stiffness of collagen scars, and high-definition MRCP that uses magnetic fields to illuminate microscopic fluid ducts without a single drop of dye, we are mapping the intricate cellular architecture of an internal organ entirely from the outside.
We are rendering the human body functionally translucent.
The provocation is this. As these shear waves and magnetic protocols become ever more mathematically precise, will the invasive liver biopsy soon be relegated entirely to the history books? Are we witnessing the dawn of an era where we will never need to use a needle to understand the liver ever again?
It's an incredible thought.
A future where the most complex, silent internal mysteries are solved with sound and magnets without a single drop of blood being spilled. That is where the science is heading. Thank you so much for joining us on this deep dive. Take a moment today to appreciate the silent, chemically brilliant, regenerative superpower that is your liver quietly working away in the dark. And until next time, keep exploring the unknown.